So you're going to say, when you feel this touch of skin, take a deep breath from me in and out, and then you're going to listen. So you're listening for inspiration and expiration. So ideally you're going to hear both. So typically when you're up here, you're hearing inspiration louder, okay? And then down here you're going to hear it sort of half and half, the same, and then down here you tend to hear expiration louder. So you're listening for inspiration and expiration, and you're listening for a clear sound, because what are some of the abnormal sounds that you might hear?
Wheezing, crackles.
Wheezing, crackles, rows, rhonchi, stridor. So crackles, little sound like that. Wheezing. And now, if you hear, what is that?
Something tight. Something struggling.
Tight.
Expiratory wheeze. Let me do it again.
So when you exhale, then.
That's an expiratory wheeze. How about this? Inspiratory wheeze. How about this?
Both.
Inspiratory and expiratory wheeze.
I was trying to catch that one. I'm like, what's that?
So as LPNs, you should be able to discern that, okay? Because you have inspiration and expiration. They both mean something different. So you need to be able to tell, was that inspiratory or expiratory or both, okay?
So it's either coming in or going out.
What's that?
Coming in or going out.
Coming in or going out, yep. Stridor tends to be a very heavy, it's almost like a snoring sound. It tends to be more here at the trachea, at the central part of the upper airway. You'll hear that very rough, almost like a snore. And it's often because there's some sort of an obstruction in that big airway. And the air is passing that obstruction, is causing that noise.
Is that more heavier resonance?
Yeah, it's a more heavier.
'Cause I got one of those.
So you guys are going to practice this. Now, the challenge comes when you have a patient who cannot take the deep breaths for you. Either they don't understand that they need to take the deep breaths, or for some
COPD.
reason they're unable. So it's very hard to do a good lung assessment without the deep breaths.
And what's the holding part? Like, you're like, hold it.
So we don't really want them to hold it, because we just want to hear inspiration and expiration.
Oh, okay.
We just want them, but we need them to take a good deep breath.
Okay.
So you need that amount of deep breath in order to really hear those sounds. So if you ask someone to breathe for you and they can't, or they don't understand, or they can't do it, it's very hard. You still have to listen, but you're not necessarily
Right.
going to get a good enough assessment. If that's the case, you're going to write that when you document your lung sounds. You're going to say, unable to fully assess because patient is unable to take deep breaths. So when you can't get a good assessment, you got to make that note. All right, so we've done our lung sounds anterior and posterior. We talked to him about his shortness of breath, his cough. We're looking for, again, signs of circulation and oxygenation in the blood. So now we can move on to an abdominal assessment.
Wow.
Now, we're not going to necessarily be able to do that here at the hearth, but this is how you would do it.
This is the one I've been waiting for.
Why is that?
I don't know. I just
It's so
I don't know what I'm
interesting,
listening to.
right?
I mean, I hear it
Yeah.
and I'm like,
Yeah.
okay, what does that mean? What does that mean?
Yeah.
But I like
Yeah.
that you gave us this little handout.
Yeah. So basically, you do the bowel sounds first. I mean, you're going to inspect first. So you're looking for symmetry
Distinction.
of the abdomen. You're looking for any bulging, any discoloration, anything, scars, whatever you can see. You're doing that inspection of the abdomen. And then you might find a colostomy bag there. Who knows? There's any number of things that you could find. So the bowel sounds you do first, because if you palpate first, it can change the bowel sounds. So you want to listen first and then palpate. And basically you find the umbilicus and you listen 4 quadrants around the umbilicus. And you simply place it rather gently on the abdomen and just listen. And have you heard bowel sounds?
Yes, but
They're little gurgly
Yeah.
sounds. It's
Yeah.
like your stomach is growling.
sometimes you don't need the stethoscope.
Sometimes you don't even need this.
You just mentioned the colostomy bag. If they don't have an organ in there, you wouldn't. What are you hearing?
Well, they would still have an organ.
Oh, okay.
Yeah.
They just make a hole to make it get
The
out.
intestine.
The
goes to
intestines
the
are what I
intestine.
meant.
Wait,
Okay.
you have
So
Temporary
what are
one.
bowel sounds? The intestine.
Oh.
What are bowel
Peristalsis.
sounds?
Peristalsis.
Peristalsis.
Peristalsis. I'm sorry.
Peristalsis.
That's right,
good.
and that's always, if that you don't hear,
Yeah.
that means there's
No,
an
one of them
obstruction.
permanent and one
Well,
of
it
them
means
is temporary.
okay. So the
Oh.
intestines should be
Always
having peristalsis, but certain things can slow it down. So, for example, anesthesia
Oh, okay.
Uh-huh.
can make them very sleepy.
Impact
And-
it? Like,
Well,
does that slow that down?
That's later. So
Okay.
right now we're just saying somebody had surgery and they had anesthesia. It makes their bowel very sleepy.
Relaxed.
So yeah, it's lazy. So it's not peristalsing the way it should. So we hope that within a matter of a few hours that anesthesia will pass through their body and now their belly will wake up again. That's what we say, or their peristalsis will start again. So that could be a reason why you have diminished bowel sounds. Constipation can also do it because it's all bound up in
Right.
there and the peristalsis isn't working anymore. So different reasons, illnesses can cause it
How about
as
when they give
well.
them like the, not the Marilax, the other one? Colace.
Colace, yeah.
Right.
What Colace does is, Colace brings liquid or fluid into the
Right.
intestine. It just, for some reason, I don't know how the mechanism is, it brings more fluid into the intestine. So because the stool is now more wet, it tends
Easy
to
pass.
move easier.
And that's the one that take a little bit longer, right?
Yeah.
Yeah.
So when you're listening for bowel sounds, you're listening for those gurgling sounds. I think the norm for bowel sounds is around 15 per minute or so. But you don't have to get too crazy about this. But basically, you're going to listen. And within a few seconds, you're going to hear a little something. And once you do, you can move to the next. I mean, the book is going to tell you should listen here for a full minute. You should listen here for a full minute. It's pretty hard to find all that amount of time to listen. So if you listen and you hear something, you're good to go. You can move on to the next
Right.
quadrant. But basically what you do want to know is for sure, is there sound in all four quadrants? So the findings are either normal vowel sounds, diminished vowel sounds,
Hyper.
or active,
Right.
hyperactive. That's when you listen and you're,
Right.
it's like if you have the stomach flu or something and it's just gurgling and gurgling, that's hyperactive vowel sounds. So we should have listened on that patient today. Yeah, we should have listened. So, okay, so you're listening for the bowel sounds and then you will document your findings.
So
There.
what's the difference in the sound as far as like if somebody say hungry versus if somebody's diarrhea or somebody's backed up?
Well, that's a good question. Yeah, I mean, they could sound the same, so then you have to look at the other signs
Okay.
that are going along.
Because I asked because last night I have a 4-month-old and last night like you could like it was loud
Mm-hmm.
and her mom thought she was hungry and I'm like, well, maybe she just need to poop.
Mm-hmm.
And she tried to feed her and she wouldn't eat and she was like in the middle of sleeping and she keep turning and you hear it and you hear it loud and then
Yeah.
I had we do we push her legs back and then she ended up
So that was a good.
So that- and that
call.
was the problem.
You knew what was.
so I figured something was going on because I heard it was loud. And I'm like,
She needed to go ahead.
let it
and
go. Right,
let it
right,
go.
right. So that's why I was wondering if like a different sound because it sounds just like when
Not
when you're
really.
when somebody's next to you and you're like, yo, is that you? And yeah, I'm hungry.
Yeah.
It sounded the same.
Yeah, it sounded the same. So once you've listened to the bowel sounds and you've inspected, the next thing that you could do would be palpation. Now, with palpation, basically you use kind of like the flats of your fingers here, and you place your other hand on top and you gently palpate. And basically you're looking for tenderness, where the patient goes, ow, they're showing you that there's some pain or tenderness, and you're feeling for softness or distension. And you're going to sort of just go on each side. So let's think about this. So if I'm palpating on this side, what organs might I be
Is that
palpating?
where the pancreas is? Or is it the other side?
Pancreas,
Is that pancreas right
So
there?
the appendix is down here. Yep.
the back, stomach.
Yep. Gallbladder is on this side. Yep. Liver is on this side. Yep. Pancreas.
Liver left. Hey. Oh, wait.
Oh, yes. You're right.
Darn.
No. Let's look it up.
You got the funds book.
Let's look it up.
You got the funds book.
So you gotta remember.
Here.
The funds book right there.
Oh, it's on this paper.
It's not in here. You got a picture of it
The
in
funds
there?
book. What's the funds book?
She has, there's no service down here.
It's in that funds book.
See if you can find it. So while he's looking that up. Now, the urinary bladder, however, is here. It's right above the pubic bone. And this is another area that you can palpate. Because if someone is retaining urine, the bladder itself may be sort of puffy and so there is such a thing as urinary retention when a person is unable to pass the urine for various reasons. And in that case, the urinary bladder will be tender and sort of distended.
There we go.
And there's a machine, again,
Ultrasound. Ultrasound.
The LPN came down and she was putting it on the little pad of clinical instructor, so she doesn't have it in the right place.
Yeah, the urinary bladder is just above the pubic bone. Which are in the lower part, yeah.
But that machine detects.
This might help you a little bit.
Bladder, that's so cool.
Well, it detects how much urine is still in the bladder.
Oh, okay.
So the bladder is like a muscular sac. And when it empties of urine, ideally it is empty at that time. But sometimes there can be some residual urine sitting in there. And the problem there is that urine sitting in there is more likely to get infected because it's just sitting there for a long period of time.
Oh, boy.
Yeah, bacteria could start to grow. So the intestine comes across like this, right? So you have your large intestine coming across. Transverse colon. The stomach is right here.
The liver's on
the
the
liver
right.
is on the right. You were right. I was wrong. The liver is over here. Thank you very much.
Where's the spleen? Where is the
And
spleen?
is spleen here?
You're not sure this
Does
one?
it show the spleen?
Sorry.
Yeah, that's your heart sounds and your lung sounds. That's okay. We'll figure it out. So, what I did want to say though, in regard to the palpation that we talked about, normal abdomen is soft and non-tender. Soft and non-tender. Now, other findings could be soft and tender, so that's not normal, because normal is soft and non-tender. Another finding could be firm. So it's not soft, it's firm.